So formally welcome everybody to our NIHR ARC North Thames Innovation Implementation Science webinar series. So I want to introduce our set of speakers today. We're talking about qualitative approaches to innovation and implementation science. And the focus today is thinking about case study of dementia. So this came about the idea that we're looking at this idea about how we do innovation and implementation science, but I've noticed that there are quite a lot of people working in this space around dementia. So we've got 4 speakers today. We're going to start off with Dr. Katie Featherstone, and then we're going to move on to Professor Alison Pilnick, Kate Ridley, and then ending with Professor Jill Manthorpe. And they're all, so they're all going to talk on the same kind of topic, but with different qualitative approaches. They're all going to talk for around 15 minutes, and we'll allow a couple of minutes just for anything that's points of clarification, but we're going to do the main discussion at the end after they've all spoken. So I think we're ready now. Katie, if you want to share your screen and kick off. Thank you very much.
Hi, brilliant. Thank you so much. I'm just going to share my screen now and get that going. Great. Well, it's great to be here today and have such a great audience. And I'm just going to present a snapshot of the work that we've been doing, a 5-year programme using ethnographic methods, classic hospital ethnography, to examine the care of people with dementia in our hospitals. And I suppose I'm here to make the case for ethnography as vital to understanding experiences and improving care. This is an ethnography, a series of ethnographies I've carried out with Andy Northcott, but of course there's a wider network of collaborators involved. And I'm pleased to say it's all been funded by NIHR, HS&DR, who've really supported this work. So, what's the issue? Well, people with dementia over the last decade have the numbers have increased dramatically in our acute setting. I'd say estimates at the moment would suggest between 25 and 50% of all hospital beds are occupied by someone living with dementia, but that's highly contested. But if you talk to any nurse in charge of a ward, they typically tell us about a third of their patient population in general acute wards is also living with dementia. There are also a group high use of emergency admissions and urgent care needs. So who are these population of people living with dementia? Well, they're actually typically living with early and mid-stage dementia. They're also often undiagnosed because they're perhaps at an early stage or a point of crisis. They're also admitted, it's an unplanned admission for a potentially preventable acute condition, so pneumonia, sepsis, UTI, but as well as being potentially preventable, they're also really treatable. So this population, they're not there because of their dementia, they're there because they have these additional acute conditions that need treatment in our acute wards, but they also should be getting their treatment and going home. What we find is this population are really high risk of poor outcomes and poor experiences. They have an incredibly poor, higher short-term mortality, with almost a quarter dying during their admission. And if we think about 2 patients admitted to the acute setting, one with dementia, one without, the person living with dementia with the same admitting condition, the person with dementia will have twice the risk of dying during their admission. So these rates are really, really disturbing. We've also known over this last decade, as this group have increased in our acute wards, there's been a huge number of government reports and inquiries that tell us again and again about these poor outcomes and experiences. And this tells us something really important. It tells us that there's something deeply systemic about the inequalities this group experience in the acute setting, because we keep getting told again and again, but there's very little change in outcomes. And it also tells us something incredibly resistant about this setting. What is it about hospitals, ward settings, where interventions seem to bounce off or they turn into something else? So it's a real site where change is needed, but as we see from these inquiries and also these these reports, we see again and again, these poor outcomes experiences continue. So what's the NHS response been to these poor outcomes and experiences? Well, it's been very reactive, very local, very limited, small interventions, and really not based on evidence, but more likely a sense of this seems like the right thing to do. So we get new types of wards emerging, COTI, RAIDs, CI, frailty wards, the dementia-friendly wards. Really, these focus on organising and grading patients by age and ability, which is actually a really long-standing feature of hospital cultures. We see a lot of outsourcing of skills. So we see dementia skills transferred to very small teams of dementia support workers, and also a high use of enhanced one-to-one and agency care to support individual people. We have a lot of identification and awareness schemes, and these actually boil down to, and these are really common across acute wards, these boil down to stickers above the bedside with an image that identifies dementia and tells busy staff attending the bedside that this person is living with dementia. We've written about this separately, and I think it's really interesting, these interventions that seem like a good thing, but actually what happens, what do they become in the acute setting, how are they used? So in response, our approach has been to think about actually, we need to take a step back, we need to actually look at what's happening in wards, we need to look at how work is done rather than work as imagined by policymakers or institutions. If we can understand that, then maybe we can think about how to intervene and support this highly resistant setting, to shape and change culture, to support people with dementia, but also to support ward staff. In response, we've obtained 2 consecutive grants from NIHR, the first looking at refusal and resistance of care, which was identified by ward staff and carers as a key concern. And then we moved on to continence care practice, which we've just written up, focusing, which is really a real priority for people with dementia and carers. As well as journal articles, we've also published a monograph. Because this research is publicly funded, this is an open access publication and anyone can download our monograph for free. So our approach has really been to deliver detailed ethnography, but also over multiple sites. Andy Northcott and I have spent a year of our lives in hospital wards observing everyday care in wards across England and Wales. Our approach is really about identifying social processes. We're not using ethnography to to look for representation, to compare sites, or to evaluate sites. Our approach is about identification of social processes. What's happening? Why is it happening? Why does it work that way? If we can understand that, maybe we can think about how we can intervene to improve the circumstances in our acute wards for everyone. And I think it's also important, if we're thinking about interventions, to think about these ward cultures, and they're very old ward cultures. The ward as a small society has been identified since the early hospital ethnographies of the 1950s. They've been described as tight little islands of vivid and capturing activity. And we also found people living with dementia really cut adrift on these islands, and that for a person confined to a hospital bed, it was really, they were defined by their condition, but also were seen as being very isolated and assumed to be really unaffected by the context, the world in which they found themselves, which actually we found had deep impacts on people. Hospitals also have been found to, of course, reflect the wider social world. We're seen as a small society in miniature. And we also found dementia as a condition was understood by non-experts within these wards in ways that reflect wider social understandings. So poor understandings of dementia and a lot of fear and a lot of stigma around dementia within these wards. And I think it's also useful to and I think something that struck us in doing our research or our analysis, that despite the huge transformations in our hospitals in terms of technology, actually the old medicine of the organisation and delivery of care in the acute wards remains relatively stable. And if we look back to these ethnographies of the 1950s, Stanton and Schwartz, Caudill, Kosa, Roth, we see incredible continuities in the way care is organised and delivered within our wards, which, you know, may also contribute to why this is so resistant. This is old medicine. So I'm just going to, because we've got so little time, just a tiny snapshot really of some of the things we found. And I think it's useful to think about culture, it's useful to think about the rules. And of course, everybody's expected to learn the rules of whatever institution we find ourselves in. And we did actually find that patients asked explicitly about the rules. What are the rules here? And as ethnographers, we also found that we felt this powerfully too. In every ward we went, as we walked through those double doors, as we pressed the buzzer to be let in, we too felt that uneasiness of not belonging, of needing permissions. What are the rules here? That hesitant sense of, do we belong? Will we be allowed to? Will we be challenged? So we found huge numbers of rules that were for healthcare staff and for patients. And they were also incredibly stable across all of these sites. So just to give you a little snapshot, so I think the key thing why these rules are so important in the context of the care for people with dementia is that there was absolutely a compulsive repetition of these rules to people living with dementia at the bedside during everyday care. During the delivery of care at the bedside, these rules were repeated to the person and explicitly reinforced. There were also a very limited range of patient responses that were seen as acceptable in the context of people with dementia, and there was very little flexibility with this group. They needed to comply to these rules, and if they were unable to comply, then actually what we got was an increased tightening of the rules for that group and for that person. So this old medicine of privileges and permissions. So here's just a few examples of the kind of ones that were absolutely very stable across all the ward settings that we've been in. One, the person must understand you are in hospital. This was compulsively repeated to people, that reorienting to reality, which actually was very disturbing for patients. Rule 2, you must not wander. Any walking in the ward was seen as highly problematic and a significant risk to the person and to the ward. People must communicate through institutionally recognised ways. So people must communicate their needs verbally to the person, but also they could use the bedside alarm. Those were acceptable ways to communicate an urgent need, but other ways were seen as really difficult for staff. 4, follow etiquette and bodily discipline. This was really strongly enforced for people living with dementia, and any spills or accidents were seen as highly problematic and could give staff a lot of anxiety. Rule 5, care needs must fit the timetables. Really powerful delivery and organisation of care to really strong timetables, both within and also to meet timetables outside of the ward coming in. For example, meal times, medical rounds, that kind of thing. If urgent care didn't fit within the timetables, then that was highly problematic for the organisation of the ward. So why are these important? Well, just to give you a really quick sense of why these are important, they're really, really important because they show us how dementia and how people with dementia are understood within these ward settings. So if a person with dementia was not able to fit within and follow these rules, then a number of really, really significant things could happen to them. This not fitting in, this rejection of the timetable, or seen as rejection of the timetable, could be seen as a feature of someone's dementia, which could start to really overshadow them and their care during their admission. But it could also be seen as willful, a willful rejection of the rules of the ward, and that too could have significant impacts on the person being seen as difficult, as disturbing the ward, and as not belonging here. But I also wanted to make it clear, and we haven't got time to cover this today, but the rules were very, very powerfully felt by ward staff. And one way in which this manifested was care work was highly restricted to the timetables. Conversations or listening to patients appear to have no recognised value within the wards. If staff did that, we saw again and again, if ward staff gave people particular attention that they needed, particularly around listening and talking to somebody in need, that could be really frowned upon and actually stopped by other ward staff and senior staff. And we also saw this tightening could actually lead to more enforcement of the rules, which led to kind of cultures of restraint as well. Our next study will follow that up, looking at understanding the use of restrictive practices in acute setting, that kind of the everyday mundane use of those in everyday care for people with dementia. And I know I'm probably running out of time now, aren't I? So I'm just going to add that we include a lot of people with dementia in our research programme. I think importantly, ethnography has got the power to make some change. So we've had a lot of impact from the media, BBC and the Guardian front page headline for our work. It is reaching policy, and I have a lot of invitations from policy to talk about the work that we do. We're using it to inform training for ward staff and capacity building the next generation of researchers in the field, and that's it. So I shall stop sharing, because that was a bit of a whistle-stop tour.
That was brilliant. Thank you ever so much, Katie. That was so interesting. And I have actually read your book as well, your monograph, which I thought was fantastic. And it's a great read for anyone who's interested. It's so nicely written as well. So really, really interesting. If not,
thank you so much, Fiona. That's very, very kind of you.
It did make me quite sad though. It is quite sad, isn't it? But it's brilliantly written as well. It's lovely. So I would encourage that. Are there any particular questions now that are a point of clarification? I can't see anything here. So I think we'll probably just keep moving on, and then we'll come to ask questions and draw it all together. So thank you very much, Katie.
Great.
That was great.
Thank you.
Right, Alison, do you want to? Yeah.
Yeah,
okay.
I'll share my screen.
Happy? Brilliant. Thank you.
Excellent. Thank you. So I should say that I'm presenting today, but obviously this is work that was done by a team of people. So the team is there on that slide. The work that I'll present comes from something called the Voice Study, which was an NIHR HSNDR funded project. And if anybody's interested to look at the full final report, because again, this will be a bit of a whistle-stop tour, then the link to the project report is there. I should also say that some of what I'm presenting today also draws on further analysis of the same data set that we collected for the Voice project, but which was funded by what was then Clark East Midlands. So some very basic information about the Voice study so that you can make sense of what follows. We collected 41 video recordings of healthcare professionals and people living with dementia on acute hospital wards as they were engaged in everyday healthcare tasks. So the pictures on the slides are just examples of some of the kinds of activities that people were engaged with. And I'd normally show extracts from these videos as part of the presentation, but because we've been recorded today and because of the ethical implications of that, I'm not going to. What I'll do instead is talk you through a couple of the transcripts as we go through. So I think it's worth saying at the outset that the starting premise for this project was that obviously lots of challenging situations are likely to arise on the acute ward for all kinds of reasons, and that skilled practitioners are likely to have developed communication practices to manage some of those difficult situations well, sometimes purely through experience and trying different things. but it's rarely possible for people to articulate those practices in sufficient detail for them to be specifiable to others. So if you want to unpick those practices and make them potentially trainable to other people, you need a qualitative approach that can both capture the level of detail of communication, but also analyse what it is about the particular practices that people are using that makes them successful in particular contexts. So rather than coming in from the outside with a checklist of what counts a priori as good practice, the starting point for us and for this project was to look at what was currently working well in that particular setting, and to think about how that could be built upon and how it could be shared and how it could be disseminated. So we used a qualitative method called conversation analysis to identify some of those practices. And we then developed and evaluated a 2-day training course, which we've now run for more than 100 healthcare professionals across various settings. So when we started delivering the voice training, trainees on the course often raised with us the challenge of how to respond to patient talk that they often described as talk that they found it hard to make sense of. And so what that led us to do was to go all through our data set and to collect all the instances of talk that appeared to be non-contingent or that was hard to interpret in the sequential context of that particular interaction. And what we found straight away was that that was really prevalent across our data set. So in more than half of our recordings, there were multiple instances of that kind of talk. And as many of you will know, there are a number of dementia-related difficulties that might make talk hard to interpret in this context. So I put a few of them on the slide there, but things like reduced articulatory accuracy or word-finding difficulties, or a sentence or a narrative that might not be internally coherent. And it's really important to say that we weren't conceptualising these as errors by people living with dementia, simply that we were recognising them in the context of the ongoing conversations as utterances that potentially challenge shared understanding at that point. So obviously misunderstandings in talk occur all the time, and in everyday talk they're normally dealt with straightforwardly through what conversation analysts call the process of conversational repair. And repair generally gets treated by participants as a priority activity. So you stop the progress of the conversation until you sort out the misunderstanding, and then you carry on with what you were talking about before. And I guess that makes sense practically, because in the absence of shared understanding, you run the risk of going on indefinitely at cross purposes. And what conversation analytic research also shows is a preference for self-repair in conversation. So you give the person who's produced the talk that's problematic for understanding a chance to put it right themselves. And if you repair for somebody else, so for example, by correcting an answer when somebody gives it, that's dispreferred in conversation because it potentially threatens face. And it does that because it potentially treats someone as not competent to repair for themselves. So talking about repair in the abstract is one of those things that's much more difficult than it is if you actually see it in practice. So what I've put on the slide here is just an example of straightforward repair that comes from our data. So we've got a healthcare professional who asks a patient, "Are you eating and drinking much?" And the patient says in a very quiet voice, "About average." The healthcare professional doesn't hear, they say sorry, and the patient repeats it, and this time on repetition it's clearer, it's shorter, average, and the healthcare professional confirms that she's heard it by repeating average. So that's a fairly straightforward response to repair. It works perfectly well to repair the misunderstanding or the lack of understanding that had taken place in this consultation, in this conversation. And then the interaction just proceeds, and we haven't got the rest of it on the slide there. the difficulty was, when we looked at our data, that this was almost the only example of straightforward everyday repair working in this way. What happened more commonly, if repair was initiated like this, was that it didn't work to achieve clearly identified or displayed mutual understanding. And instead, the attempt at repair could go on for quite some time and often would ultimately have to be abandoned because it didn't get anywhere in resolving the issue that was being misunderstood. So if I show you an example of that from our data, the staff nurse here has been checking the patient's blood sugars, and we come into this extract just as she's reading the results. So that's what the "there we go, all sorted, got what we needed" refer to. In response to that, the patient says really, really quietly, and we only hear this through headphones and repeated listening, as "I don't know what you're doing." The healthcare professional evidently doesn't hear it, but she knows that she's missed something. She says, "Pardon." She doesn't get a response for 4 seconds, and after 4 seconds she tries again, and she's a bit more specific this time. "What did you say, darling?" There's another pause, and the patient says again very quietly, but this time a bit more audibly, "I don't know." That's how the healthcare professional hears it. She repeats the "you don't know." There's another long pause in which the patient doesn't offer any further clarification, and the healthcare professional doesn't pursue it, and then she topic shifts. She changes to talk about what they'll do later on that afternoon. So most attempts in our data set were met with similarly unsuccessful attempts at clarification. And what that led to, as I say, was often extended sequences without any kind of resolution. So I guess that begs the question, if everyday straightforward repair doesn't work, what do healthcare professionals do instead? And what we found were a number of approaches that healthcare professionals used where rather than draw attention to the potential trouble in the interaction, they found ways to pass over it and to continue with the interaction instead of stopping for repair in the way that you might ordinarily do. And we identified 5 different ways that healthcare professionals did that in our data. And all of those ways enabled the interaction to proceed and for the person living with dementia to remain an active part of it. So they avoided making an issue of competence and threatening anybody's face in that kind of way. So what I'll do really quickly is just talk through each of these approaches, and then I'll just come back to some concluding comments at the end. So one thing that healthcare professionals could and did do was make minimal responses. So things like continuers and non-verbals that encouraged continuation. And that's what happens in this extract on the slide here. So using continuers allow somebody to continue their turn at talk, and they potentially allow for understanding to become clearer as the talk progresses. But the issue with these is that they'll likely only work for so long. So you can see in the example on the slide that the healthcare professional produces a number of, the person living with dementia produces a number of terms, some of which we can't pin down enough to transcribe. So in line 305, we know that something was said, but we can't pin it down enough to transcribe. And then in 308, we get talk that it doesn't have an obvious relationship with the activity at hand. In response, the healthcare professional produces minimal acknowledgements. So we get okay, we get yeah, we get nodding. But in 312, these get identified by the patient as inadequate or unconvincing in some kind of way. So he says, "Do you know what I'm talking about?" And the healthcare professional confesses in 313 that no, not really, she doesn't. There's another pause, and then the healthcare professional moves to close the conversation and to move away from the patient. So continuers work sometimes, but they're probably time limited, because after a while somebody is likely to pick up on the fact that this is a more minimal engagement than might be expected over a longer period of time. The next approach that healthcare professionals use in our data is repetition. So in this extract, the healthcare professional and the person living with dementia are engaged in shaving. And at line 76 and 78, the healthcare professional initiates talk that's not directly related to the shaving. So he says, what else have you got today then? What are you up to today? The person living with dementia's response in 79 is hard to interpret, in the sense that it's not an obviously fitted response to the question. But what the healthcare professional does is repeat, with some grammatical reframing, part of that talk, and then tag on a confirmatory or agreeing all right at the end of it. So again, the talk here gets treated as if it makes sense to the healthcare professional. It avoids any need for repair, and it enables the person living with dementia to continue talking, to continue telling the story. So what we saw in our data was that using this practice of repetition allows the healthcare professional to show that they've heard and understood something specific. And in that sense, it's much more committal than a minimal acknowledgement or a nod. It passes the conversational floor back to the person living with dementia. It allows them to continue their turn. But the obvious limitation is that although it might be quite common in our data, you can only use it where you've heard and understood enough of something to be able to repeat it in this kind of way. So the third approach our healthcare professionals used was to respond to the emotional tone of the person living with dementia's talk. So the example I've got on the slide here is from a patient whose talk sounds distressed, and the healthcare professional has come to check a plaster cast that she's got on her arm. The hard to interpret talk, which begins when the healthcare professional has just finished putting the cardigan back on the woman living with dementia, isn't obviously responsive to the prior talk, there we are, and it describes going home with her dad, who is deceased. And what the healthcare professional does is avoid challenging the patient's reality. Instead, she picks up on the emotional tone, she picks up on the distress, along with the reference to dad, and she uses that to frame a question: are you missing your dad? That question gives the patient an easy option for an aligned response, which she takes, yeah, and then she goes on to continue her turn at talk. So that's another way in which healthcare professionals manage to keep the conversation going and manage to maintain a sense that the person living with dementia is included in the conversation and can retain the conversational flow. The fourth approach that we saw was closing one topic and shifting to the next. So some of the approaches we've shown so far potentially work well to keep a conversation going and to keep a person living with dementia as an active participant in it. But sometimes on an acute ward, there will be tasks which have to be completed within a particular time frame in order to provide adequate care. And I know that I'm short on time, so I'm not going to go through this extract in detail, but it's worth pointing out here that the healthcare professional has an attempt at a couple of the other approaches that I've talked about so far. So there's the there's the minimal acknowledgement, and there's the no you don't, no you're right, the responding to the tone. Before, in line 192, she gives a final confirmatory no, and then she moves to shift the topic, so you know when you've been discharged from the hospital. So she moves on to talk about what arrangements there might be for discharge. And when we do the voice training, topic shifting is a really important point for reflection. So trainees often reflect on the potentially good reasons that there might be for making a topic shift in the face of hard to interpret talk. Because I guess one way to look at it is that you're potentially closing somebody down. But trainees often talk about the way in which facilitating a patient to continue talk isn't necessarily the only person-centred approach, depending on what care needs might be at a particular time. And then so lastly, on a very few occasions, healthcare professionals were able to treat the hard to interpret talk as though it was related to a particular task at hand, even when that transparently wasn't necessarily the case. So in this extract, the healthcare professional is wanting to get the patient to stand for a short time to change position because there's a concern about pressure sores. So the healthcare professional asks the question, am I all right to just stand you up for a moment? And she gets the response, it depends. When she follows that up, the patient says what it depends on is how big it is, how wide it is. So that's potentially hard to interpret in this context. But what the healthcare professional does is treat it as a question about the standing. And obviously that option is only available to the healthcare professional where the content of the patient's talk makes that possible and relevant. But in this example, it works. In this example, the patient accepts that interpretation without challenge, and she does go on to stand up a couple of turns later. So I know that's a really kind of whistle-stop tour of a set of different approaches that we found professionals using in our data set. But if I just try and bring some of that together to draw some conclusions in some way, I guess what we would argue is that avoiding repair in this setting has two important consequences. So practically, it avoids the fact that explicit repair might not be successful, and based on our data set, it probably won't be successful. But instead, what's likely to happen is that you enter into a longer sequence where things ultimately can't be resolved. But morally, it also avoids the fact that explicit repair can challenge competence. So it avoids the difficulties over the threat to face that would follow from repeated failed attempts at repair. What healthcare professionals do instead is respond in a range of ways which avoid flagging up any lack of competence, but at the same time they acknowledge the patient's contribution and they also allow the interaction to proceed. What's really important is that which approach is most effective or most appropriate depends really heavily on local context. So obviously you can only use repetition if you've heard or understood something anybody said. You can only respond to an emotional tone if you're clear what that emotional tone is that's being expressed. But really what I'd argue is that these findings are an empirical demonstration of the really high levels of skill that are needed for dementia care. And that also what they show is the limitation of prescription checklist or prescriptive checklist approaches to training. Instead, if you equip practitioners with knowledge of a range of possible approaches, that enables them to assess the local context and to think about what might be most likely to be appropriate and or effective in the actual interactional moment. So what I hope the presentation has shown is the importance of qualitative methods and particularly those that focus in detail on interaction in the development of training and in the improvement of care for people living with dementia. And I'll stop there. Thank you.
Thanks, Alison. That was really interesting, and I think I think it was really nice to see those two together. Katie's work followed by yours, Alison. So I think we'll move straight on. So if you could stop, share that, thank you, and then we can. Yeah, we've got lots of claps coming in. Brilliant. And I think we'll move straight on to Kate, if that's okay, just because we're a bit short on time.
I will just get the slides up for you. There we go.
That's brilliant. Thank you.
Right, I'm Kate Ridley. I work for the Social Policy Research Unit at the University of York. And Fiona asked me to speak a bit about implementing life story work with people with dementia in care homes. This is kind of referring back to a project that we finished a little while ago. But she asked me to speak specifically about the implementing of the intervention that we did, almost like as a case study, as part of this wider feasibility study looking at life story work in a lot of different contexts. And I've called it Best Laid Plans, and you'll see why as we go through. So this is it was an NIHR funded research, just like the others. I'm going to give you a little bit of an overview of the research that we did, the background, our plan, and then what actually happened as it played out. And Fiona's smiling. And I'm going to link it to normalization process theory, but I am in no way an expert on this. We didn't use MPT, but in thinking about this presentation, I was thinking, well, how does our observations fit with that kind of more formal theory? So this project came out of the dementia strategy and the push kind of starting in 2011 to include more people with dementia in research, and also in care home research in care home settings more widely. And this is still going on, and there's quite a long way to go. The targets for increasing the numbers of people with dementia in research haven't in any way been met, and there are still a lot of issues and things to be worked out in terms of care home research. And that's in some ways because research in care homes is a messy business. Excuse me. And we knew this back in 2011. I was in a School for Social Care Research review, pulling together research that had already been done in care homes, showing how complex it is to make this happen, and progress can be influenced not only by the cognitive and physical frailty of residents potentially, but staffing pressures as well, because in some ways care homes are unique environments because they're both homes and workplaces. And I would add in that the management context is really, really important as well, as you'll see from our experience. And also the kind of divergent priorities. You've got, as I say, it's people's homes, people live there, you've got the staffing priorities and management, but you're also adding in research as another kind of priority. So we were there to collect data, to observe the implementation of this intervention. And that was nobody else's priority in that setting. Everybody else had very different priorities, understandably. So this was an NIHR funded feasibility study. So it wasn't a full evaluation. We were looking at life story work almost like as a concept, trying to bring together what was already known about this approach to working with people with dementia, which I think I can best describe as a process and a product. So it isn't just kind of reminiscing about someone's life. It is kind of like involves a process of getting to understand a person's life, or what's important to a person in their life. But it's also a product in that most life story work involves making something. It could be a book, a report, a folder, sorry, some kind of film, or it could be a collage, lots of different ways of doing it. But it's to be used in some way to support the person, improve their care, maybe as a hook for conversation and communication, something to enjoy with family and friends, lots of different uses of it. So one of the things we did in the study was explore those kind of uses. We did focus groups with people with dementia, family carers and staff who'd used life story work in their work. And we also did a big literature review, our national survey about how life story work was currently being used in various settings, and also how carers had used it with their people they cared for. And then we did some feasibility work looking at how different ways of kind of collecting data in order to think about evaluating life story work in real world settings. And we looked at care homes and we looked at hospital wards. And I'm going to talk about the work that we did in the care homes, because the hospital wards, in theory at least, were already doing life story work, but in the care homes, they were going to implement it fresh. So just to say, this was a messy process, and it has not been cleaned up you know, sometimes we get the kind of we miss out some of the messy details, but I was asked to talk about it openly, so here we are. Okay, so the plan. There were 6 care homes. This was there was a care homes provider that we worked with throughout the study who were intending to implement life story work anyway. There was a big provider, not-profit provider, who got over 100 care homes, and they were going to implement life story work anyway. They were very keen to do this. They'd got a dementia care consultant who was very up on life story work and wanted to get it going everywhere. But they thought that taking part in research would be a good way of kind of kickstarting that and building some evaluation into what they were doing. Very committed provider. They selected the homes that they were going to work with. These were like ones that were really keen to be early implementers. So in theory, there was a lot of buy-in. We met with the care home managers, and yeah, everybody was very keen. The plan, as I say, they were kind of taking responsibility for implementing life story work. They were going to run training. There was also talk of some kind of maybe buddy system. Their training was informed by our literature review and our focus groups. We provided the kind of resource, so paid for the person to go in and do the training, who was actually the dementia care consultant, and they ran training at different times of day to fit with different kind of patterns of people's shifts, and offered it to all staff in the 6 care homes. That was the plan. From cooks to managers, so everybody's responsibility to do life story work as part of your job, find out about people's lives and build it into the care that you provide. And what we would do is they would randomly select 10 participants that they were working with and collect data from those and from their carers where they had them, and also from the staff who were doing the life story work. So what happened in practice was that 2 of the sites withdrew before we even got started. But these were replaced, and actually that wasn't much of a problem really. The ones that replaced were also really keen, and I can't even remember which ones they were. It was fine. There were 2 others that had their management changed. They stayed in the study, but their management changed before it even started. And then there were multiple changes throughout the 6-month follow-up period. And so these managers had inherited the decision to take part in the research. It wasn't their decision, they didn't own that, and that did have consequences. So in both of those care homes, the managers were less interested in the intervention. There was confusion over whose responsibility it was from the staff and the managers. So we either got a kind of, from the managers, I don't know anything about this, or from the staff, oh, we've done some life story work for you. As if they were kind of doing it for us as a favour rather than it being an integral part of the work that they were doing. And the research, there was similar kind of problems with engagement in the research. So it was harder to arrange fieldwork visits. People didn't answer the phone. They weren't keen to kind of make the time. Sometimes we turned up and there was nobody there. And so there's a little extract from our field notes here where it said, I popped up to see the business manager who didn't recognise me, didn't seem to be expecting me, and also said she didn't know anything about life story work. But the care manager, who was currently off site, probably would. And she said the staff would know if they'd done any life story work. So it's kind of not my problem. They'll know if they're doing it. And you could see the consequences of this in when we kind of like summarised where life story work had actually happened in the 6 sites we were working with. Now we originally said we'd work with 10 participants in each site, but because of various issues, we had different numbers in the different sites, but you can see there's percentages there, and the 2 care homes where they had multiple changes in management I've actually highlighted because they basically didn't do much life story work, whereas you can see in some of the others things seem to go much more smoothly. One of the things that helped things go more smoothly was kind of legitimation from the managers about this being something that is okay to do in your work time, both the research and the life story work. So there's an example here that's about the research from the field notes again, where we said, we did staff baseline questionnaires in the morning, starting with the manager who sat with us in the communal area so other staff could see it was part of the working day and not something that had to be done in their own time. And that seemed to really make a difference. And kind of understanding that this was a shared responsibility. It was kind of everyone's responsibility, but also that some people, it was important that some people took a lead and supported others. So the places where it went well, it was all staff's responsibility to, maybe while they were doing personal care, talk to people with dementia about their lives. But a designated worker had dedicated time to compile and present this information that was being collected by everyone to make these life stories that could then be used to improve person-centered care over time, or for people to use with their families, or however they wanted to do that. So here, this was in a care home that actually did really well, but we spoke to the manager on a particular date who said that staff were feeling a bit overwhelmed, and the result was struggling to get going with life story work, even though they'd got some good ideas, didn't have the confidence to put it into action. And they decided at that care home to backfill the activities coordinator for 2 full days to support the other staff to get going with life story work. And the activities coordinator was experienced in this sort of work, so that was they thought that would work well. But this wasn't something that was funded through the research. It wasn't resourced. The implementation wasn't resourced in that way. That was that particular care home saying, you know, we're going to this is how we're going to make it happen. And that was care home 1, I think. And as you can see, I've highlighted the 2 where we had kind of 100% of the people involved. Life story work was done with those. Both of those had activities coordinators leading the work, and then some information collected from care staff that was kind of compiled with that. And they both had consistent management throughout the project. And they also both used a tailored, individualized approach, which was what was, you know, that was what was in the training. That was how the good practice approach that was in the that came from the focus groups we did and things. So this issue of resourcing people's time kind of came up when we did some interviews after the research. We went back and talked to staff about their experiences of implementing life story work. And this is from one of the care homes that did really well, but they said, look, it's great that the provider wants to get involved in these kind of studies, but I do think that they need to offer support to the staff. And if we're going to be doing this study, and we wanted to do it, and we should, there should have been staffing arrangements made to free up time for people to do it properly. So even though it was something that was supposed to be integrated as part of what people do every day, so someone's saying it's not the cherry on the cake, it's the cake. Everybody does this as part of how they provide care. People saying this is new. This is a new thing. We don't know how to do this, and we have to work it out, and that needs to be properly resourced, and we need to be properly supported. So I said I'd make some links with MPT, which, as I say, isn't my area, but just by looking at the MPT toolkit, I could see clear kind of links between what we observed and that kind of more well-established framework around implementation. Those managers who inherited that decision to take part in the study, they didn't see the value or the benefit of the intervention or of the research. They hadn't internalised that value, and that translated through to them not really prioritising the work, not supporting their staff to prioritise it either. Differentiation was also something that was a problem. In one of the sites where they didn't really do much, they were saying, well, we already do this. Because when residents come to our care home, we get information about their lives, we put it in a file, we lock it in a drawer, and so we do it already. So what do you want? Whereas actually the good practice kind of messages were all about an individualized approach, which valued kind of the voice and the perspective of the person, and create something that they could use and they could own, like an active kind of living document that would support person-centered care, not be locked in a drawer somewhere. So we talked about legitimation, so managers leading by example, and also this issue of activation. So yeah, okay, we had some training, but what next? And that people really needed support to get going, and there needed to be kind of it needed to be someone's responsibility to make that happen. And this seems to fit with this idea of collective action, that it was everybody's responsibility, but they all needed to know their roles within that. Yeah, so the risk is that everybody's responsibility is no one's responsibility. People need to understand their unique contribution and how these all combine. And also the issue of resources, even in sites where there was high buy-in from staff and managers, the lack of dedicated resources, lack of time, lack of money to backfill staff by resources did impede implementation. So to sum up, this was real world implementation of life story work. So there had been studies before where they said, well, we get a clinical psychologist to go in and work with a person with dementia every week for 10 weeks, and then we look at quality of life before and after or something. And they go, oh yeah, look at all the potential of this intervention. But actually in the real world, there was so much more to take into account in order for it to be this integral part of the way that people worked, which was how it was felt it should be used in practice. It was very, very influenced by management context and leadership in terms of coherence and cognitive participation, that kind of buy-in from the people involved and their understanding of what they were doing. And there was a real risk that everyone's responsibility became no one's responsibility, and that it really needed to be adequately resourced in order to get going and be embedded. So MBT would have been really useful. We should have probably used that. But looking back, it's a helpful way of making sense of what we learned as well. Just some references, which kind of includes the actual study, if anyone wanted to look back at that. And yeah, any questions, but I know we're doing those at the end.
Thanks, Kate. That was great. Thank you very much. So if you don't mind, we'll move on now. Thank you. I thought that was lovely. Really, really nice. I think it linked really nicely to the others.
So afternoon, everybody. And it was very nice to see people in person, some of them with the camera on and some of them whose names I know very well, and to say hello, because usually I think we're probably missing now the opportunity for corridor conversations and things like that. But I've got not too much time, and I've been asked to focus on something a little bit different, which is about the potential for synthesizing qualitative evidence as a contribution to policy. And I think that's probably a big gulp, isn't it? But as you can see, I work at a policy research unit, so I suppose I've got this straw. And I'm going to be looking at 3 particular studies, and also talking about a little bit about methods. So I'm going to be talking about a study we did on handovers in care homes. So this links a little bit to Kate's study about the culture of care homes. I'm going to be talking about something called timely diagnosis of dementia in the context of policy, which was particularly keen on early diagnosis of dementia. And then lastly, talking about a group of people who are have not often featured in much dementia research, which are people who have experiences of homelessness. And then I'll be making some policy context comments as well. And I'll be posing a challenge to you because it's the end of the day and everybody's probably terribly tired in this very hot weather. So let's rattle on. First of all, just to say that I think in policy research, we've relied hugely on interviews. We've seen it as a way of asking people what they think, writing it down, presenting it, assembling it, mixing it up and stirring it in a pudding basin and so on. And we are learning a lot more about interviews with people with dementia all the time, but also that they are not the only game in town. And my colleague Kritika Samsi and myself produced a methods review on interviews what I think was just about pre-COVID, and we found that very helpful to think back to our and debate amongst ourselves how interview methods are changing. And I suppose the one key thing that we found in that was that people living with dementia are also engaging in research, in interviews, and want to participate, even to some extent more limited, but for a large number of them, they too are interested in what we're talking about, which are methods and accounts and stories and images and so on. So let's turn to the 3 studies that I'm going to mention. And the first one I thought I'd mention because it had absolutely no impact on policy whatsoever. And I thought that's really nice to do sometimes, because there's an awful pressure to say, oh, how is your study going to influence policy? And when we write bids, we always over egg that pudding, don't we? And talk about it being of real interest to policymakers. And if a policymaker actually had the time and the energy to read all the studies, they'd never do anything else at all. So we probably promised that this would have implications for policy, but believe me, I don't think it has absolutely any at all. But what it did do for us was a really interesting ethnographic approach. So that links to our first 2 presentations about exploring something that was under-researched, that you could really only get there when it was happening, and that you had to experience it to see what what was going on. And I'm sure most people are familiar with handovers as being used in the NHS, but they're also very common in care homes, when one shift goes and another one takes on. And we didn't want to define it too much about exchanges of information and written records and so on, because I think our experience in care homes was that if you've been to one care home, you've been to one care home. They are very, very variable, even if they're owned by the same corporation or whatever. And we decided we wanted to have a study of handovers, and we would be there at that time. Of course, this is a bright idea when you are thinking of all these things, but when you actually have to get up at 6 o'clock in the morning to go to a handover at 7 o'clock, or you're there for the 10 o'clock at night handover, as I was on one memorable occasion, you begin to regret this enormously. But this was the only way to get there. And of course, handover is a term that we're using in a jargon or maybe a professional sense. Not everybody use that. They talk about shift change and so on. So part of that, I think, of the joy of qualitative research is you listen out to the language. We did do some interviews, partly to get the context, to ask people what sort of shifts there were. In care homes, as in hospital wards, there are staff coming on and off duty pretty frequently. Some people work half shifts, some people work time and a half shifts and so on. And we also wanted to know what record keeping systems there were. Big corporate homes do have slightly more formal record keeping systems, but there are an awful lot of middle-sized and small homes where records are still paper records, filing cabinets, locked filing cabinets so that nobody else can see your records, as I think Kate was indicating most recently. So that too placed it in context. So I think we're learning that interviews do have a fit and a purpose, even if you're doing observational data collection. We found loads of interesting data. I could go on for hours talking about how really, really interesting it is to see what people do when they're going on and off shift, particularly if they've done a 12-hour shift when they're absolutely knackered. But did it have messages for policy? No, I don't think so. We think it's interesting to practice, and we've talked about it being of interest to nurses working in care homes and other people thinking about care homes as systems and so on. We thought it was interesting to researchers because I've read numerous studies of care homes, and very rarely have I ever seen this handover moment commented on. And we think perhaps it's interesting to a regulator because it's quite a seminal moment in time, isn't it, about record keeping, about information exchange and so on. And at a stretch, I suppose you could say it was interesting to commissioners. So no surprises. I think when the next revised dementia strategy comes out, there is not going to be anything about handovers at all. I've put this image here because it's the one image that's stuck in my mind, and how useful images are. It was the number of keys that were handed over, much like a sort of jailer key, but it wasn't a jail. It wasn't a jail, and quite clearly that was not what was happening. It was just illustrative in one care home that there were so many keys to so many cupboards that the ceremony of handing over the keys at 8 o'clock in the morning and at 10 o'clock at night was actually important. And if you went home and you hadn't got the keys to the gardener's, if you went home with the gardener's keys, which were all on this big bundle, then you were in real deep trouble, or the keys to the food cupboards and anything like that. So to me, that key moment was important, but not contributing to that rather negative picture of care homes about being total institutions wrapped up in their own worlds. It was the sheer practicalities and the non-technological basis of many homes. So the point of this study then is to say not everything has policy implications. You'll be forgiven, and hopefully we were forgiven in saying we probably overestimated completely, overestimated completely that this would be a policy relevant study, but fortunately we had forgiving funders. The next study, though, I think contributed more to a wave of research that was coming through in the early part of this century about diagnosis on dementia. And some people on the call will probably remember this suite of studies that were going on in many areas, talking to people about diagnosis, and not just the seminal giving of the diagnosis, important as that is, but also the processes that led up, sometimes to blind alleys, sometimes to God's waiting room, you name it, the processes of perhaps seeking a diagnosis or at least some decision. Not the term diagnosis wasn't always used. at that time, the National Dementia Strategy and many other documents talked about early diagnosis. What was the problem was late diagnosis. The solution, therefore, was to incentivize and to have a social movement demanding early diagnosis. And we contributed, I hope, I think we did, in saying, hang on a minute, maybe it's timely diagnosis you want, when the person is ready, when everybody else is ready, when it's appropriate, when they're wanting to know, and don't force feed people with a diagnosis if they're not quite ready for it, and think about that moment and the seminal moment it was. And of course, realizing for many people that diagnosis was not the end of their journey, because they were left in managing uncertainty, particularly as that new diagnosis of mild cognitive impairment was coming through a lot more. So we used good old sociological terms like being in it was all about liminality and so on. We also talked about that movement from forgetfulness or confused to dementia and how those terms operated in various places. We did this through 3 memory clinics. Memory clinics, I'm afraid, are just like care homes. Once you've been to one memory clinic, you've been to one memory clinic. And we've successfully managed to recruit 27 people with what they had at the time memory problems, they weren't diagnosed, and 26 supporters and carers. And here too is an interesting part in dementia research. We've almost used the word carer as a replacement for next of kin, haven't we? But these were not carers at that time. They were people who might have ended up being carers, but they were family members, relatives and so on, accompanying mum and dad to a clinic, or their spouse or partner and so on. So I think that hopefully added something to policy making, but it also gives us pause for thought about saying, well, what do you mean by a policymaker in this area? Are we talking about policymakers in terms of the organisation of the National Health Service, locally commissioned and so on? Are we talking about professionals who in a sense often cross that boundary and make up their own policies and procedures? Or are we talking about the emerging new intermediary bodies such as NICE at that time, which was then talking about dementia guidelines and so on? And I suppose coming now, and particularly with the benefit of hindsight, I think in policy terms, we're realizing that we mustn't underestimate the influencers in policy making. These are not the same as policy makers, but they have a particular role in highlighting, in identifying certain subjects, in bringing them up into the domain, such as politicians being unable to ignore them, and then policy making probably identifies them as something where something needs to be done. So I'm going to be asking people to think about who an influencer might be, so store that in your heads at the moment. The approach of funders to policy recommendations also changes. I remember when the NIHR was very cautious about making policy recommendations, and you would write a policy recommendation in your final chapter and they'd say, oh, that's a bit political, isn't it? Maybe you could say more research needed in this area. Fortunately, I think for all of us, that has changed somewhat, and they're less concerned that policy recommendations are troublesome, that really they have a place in research where appropriate. And of course, policy recommendations need to have the nuance and the sophistication of any other recommendation, rather than saying society should be nicer or more money is needed. Requiring us, I think, to be a little bit more specific about which policies we're talking about and what changes we would see. Again, I think as everybody who's spoken this afternoon has talked about metaphors and stories. In this particular study, we use the word a labyrinth. People were going down the labyrinth, most of them without the ball of string. But we also have used other metaphors and hung on to them as really representing what we think happens a lot in dementia services, which is, up until today, I'm absolutely sure people are sent on an information merry-go-round. People pass them from pillar to post and they go round and round with people telling them that the same, or that if they only go to so-and-so, they'll have the information and so on. And I think for those of us who have an interest in social prescribing, we'll want to see whether or not that too joins the information merry-go-round, or indeed actually says, stop, get off, this is the one place to go. And as I've said, I think we didn't recommend solely the change from early to timely diagnosis, but we were there with a number of other researchers, and clearly the other stakeholders, such as the Alzheimer's Society, in saying perhaps the term needs to be changed. So small words mean a lot. I'm going to talk about my second study, which is one on dementia and homelessness, a big study commissioned by the NIHR, in which we talk to people not street sleeping, because older people by and large are not street sleeping. Most of them who are homeless are accommodated in temporary accommodation in hostels. And we learned a lot about talking to people who had memory problems. Again, that was the state we had to use because dementia was not evident in there, but huge lessons for how to locate people, locate hostels. They're not just sort of places like the CQC register. You have to hunt them out, and they are small or they are very large, as this one here. How to recruit hostels. They're not part of the NHS, or CRM is not involved in them. How do you consent people who may have memory problems, but equally maybe under the influence of various substances? Where are you going to do your interviewing, etc., measurements, assessments, and records. So a really nice study to think about the practicalities of collecting data. And as we're talking from a UCL perspective, how good it is that Penny Rappaport has got another grant to be able to take this study forward to develop some implement some changes to practice work with people who have got dementia or thereabouts living in hostels. And that's great. That's not exactly the policy change we want to see, but a step forward about developing an intervention. But dementia and homelessness has got lots of policy hooks, and I'm going to use that analogy. These look rather sharp and barbed hooks, by saying how sometimes you're working on a study and you have to choose which policy communities you want to engage with. First of all, it could be homelessness is part of the diversity of dementia experiences, and there is interest, as you'll have seen, in homelessness and policy that has been amplified in the pandemic. There is too about a 20-year now real interest in homelessness health. Again, a lot of that in the North Thames area, which is a great tribute to clinicians there, that they have worked hard about saying, why is it that the average age of death for a homeless man is 45 in the UK? What a scandal that is. And for women, it's even younger. There's interest too in older homelessness, and just today there's been some activity in Parliament around older homeless people through Age UK. But one of the challenges is that the policymakers are situated in various government departments, most of which change their name quite often, and there are very different local stakeholders. But there's always a national dementia strategy to think about, and to think about revisions there, and of course to talk about policy making as it affects practice and the training and the investment in training for different staff. So it's maybe not to give more training to highly trained staff who have a lot of educational resource, but to staff for whom training is very much under-delivered, I think, such as people working in homelessness services. So, and the quote here is just about illustrating how people who are working in homelessness services are working with people who might have been on a hospital ward, might have been in the care homes that Kate was talking about. He would often ask what we'd spoken about, but he knew when it was mealtime. So an illustration there of the work of the staff as well. So just to begin to sum up what I've learned, which is probably not too much, but to say what I've really learned is that knowing a bit about social administration is valuable, and to know what a white paper is, a green paper is, just to have that tool in the toolbox really of social administration. You can listen to Today in Parliament, you can do a bit of social administration revision courses, but it really does help, I think, if we're going to engage with policymakers. And of course, we've got to keep up to date on that, knowing when the dementia strategy is being revised, knowing which new games are in town in terms of documents and so on. Hearing policymakers speak, I think, think is also really important. So although you think, what on earth am I going to a conference for? But actually, if you listen and start to tune in the same way as the conversational analysis that we heard about today, just to listen to that jargon and their metaphors, but also their mood music as well. And then really knowing the policy documents, whether it's a dementia strategy or the NICE guidelines or the Care Act guidance, so that we can draw on that to underpin our studies. Asking questions is equally really important. Just ask the simplest of questions of people. And of course, if we're going to make messages for policymakers, keep it short and keep it simple, I think is what they universally will say. So a challenge for us, I did this game in relation to dementia, maybe in the chat, or at least things to take home with. Who would people think would be the 3 most important policymakers in dementia in England? And who would you think would be the 3 most important policy influencers in England around dementia? I've got my own suggestions. I very much welcome hearing from other people, but when we talk about who they are, I think that also helps us with our studies, because we're writing for certain readerships as well. And sometimes we think we know them, but perhaps other people have other ideas and can say, well, you know, you really want to see so-and-so because they're incredibly important at the moment in time. So I'm going to stop there. I, of course, have got to do all the acknowledgements and disclaimers that everybody else says. And as you can see, I'm from an ARC, which is in South London, and it's based at King's. But as always, we're incredibly pleased to be working with North London and or North Thames, and to be working with colleagues from the universities and other places that are represented here today. So look forward to having some questions, although I do have to head off to Dublin, in a little bit of time. Thank you.
Thank you, Jill. That was great, and a really nice end, I think, to bring together what everybody had said. Now, as Jill's just said, she's got to leave at 2:30. Oh, somebody spotlighted me. How unfortunate. She's got to leave at 2:30. So I'm wondering whether if anyone's got any very particular questions that have come up, we can have questions in the chat. I'm not sure if we've got any questions in the chat as yet. But if anyone's got any particular questions, that would be great. And we can start maybe with Jill. You can either type the questions or put your hands up, although I can't see everybody now because someone's changed my screen view. Okay, well, I'll kick off, Jill. I wanted to know what you thought were your 3 most important influences in particular. I thought that was really nice. So that's a really nice way of putting it. So I'm quite interested to hear what you think.
Sorry about that. I think they change more rapidly than policymakers. So a few years ago, I would have said that the editor of the Daily Mail was a really key policy influencer in dementia. I would have put, because he had both personal interest, but also his readership interest. And it was, you only needed to open the Daily Mail, particularly the health bits, and there was something about a magic cure for dementia just around the corner, but also any other stories there. So I do think that I don't think that's so prominent at the moment, but I do think we often underestimate in academic terms the influence of those newspapers who are really important. I know they're going to be doing something on day centres shortly, and particularly dementia day centres, and probably I think that will have an influence that those of us working on day services would have loved to have had. So I suppose my top list at the moment would be the people behind John's campaign during COVID, the residents and well, the relatives of residents who feel that they have been, their human rights have been ignored in visiting relatives living in care homes during COVID, and it has been too much infringements of liberty. And I think I would say that they have been very influential in the last year or so. So it is unpredictable, isn't it? The other influence I would say actually, before COVID, I would have said people in the judiciary were very influential. People like Lord Justice Munby, whose classic phrase of saying a gilded cage is still a cage had a profound influence on risk taking in dementia services, that you could wrap people up in cotton wool, but that was no good. Again, this is pre-COVID, so again, perhaps that space is being occupied by John's campaign and so on. And then my other ones, I think, may well turn out in the future to be places like the Good Law Project, which you'll have seen have been doing work on PPE and on other COVID related things, and really thinking about the influence of dementia and law, which perhaps we who've concentrated more on services have not always stood back and said the law really matters in terms of how contracts are awarded, the way the rules are applied, going back to Katie's thing about rules being really important. So those are my possible changing influences at the time. If you said who was the policymakers, I think obviously the Secretary of State, but also the Minister for Care, and one of the junior ministers at the Treasury, I think, are the key. They are the ones who are going to be signing off policy. If we agree that, if we define policy as the people who sign it off, if we say not, then I would go for people like Alistair Burns and Martin Rosser and so on as being on that borderline of policy stroke service, which is an important interface. Does that make sense?
Yeah, I mean, I agree with you. I certainly agree with you. I would have, the one that really matched mine was the Johns campaign. And I would have, very definitely said that, I think. And I think a lot of Twitter has had alongside, what's happened on the media, I think there's been some amazing conversations, bringing lots of different people on Twitter, actually, that have been very strongly led by John's campaign and, copying them in and all the rest of it. So, I agree with you. I think that's been a really big thing more recently, but it is interesting to see how it shifts. Anyone else got anything to add on that? I know you've got to go in a second, Jill. I really enjoyed it. I thought it was a really nice talk. I think it was really interesting to see how and I love your starting with not everything has to, have an influence on policy. I just think that's such an important thing to say, that actually, and for me, it kind of resonated across what other people were saying. I really liked what Katie had said, where she said, actually, we need to really understand the social processes of what's going on before we can intervene. So, and I think that fitted really nicely with what you were saying, and also Alison's work, where we've got to understand what's happening before we can say, this is how you do it. So for me, it tied all those things up. And of course, what Kate was saying about we can have this great idea, but what happens when we try and put it into action. And I think that was just a really nice way of pulling it all together. But thank you very much. I don't want to stop you from travelling to Dublin. So just leave whenever you want to.
Yeah, great. Well, nice to see everybody, and thanks very much for inviting me. And people can always email me if they want to pick up. So have a good rest of the afternoon. Bye. Thanks very much. Thank you, Jo.
Jemima said, all the panelists have done amazing work demonstrating qualitative research can have real impact on policy and practice. Any tips for early career researchers about how to convince funders or clinicians this is the case? Well, I totally agree with Jill that research doesn't have to be this. Unfortunately, funders aren't always on the same page. So she's asking how you think early career researchers can convince funders that qualitative research can have this impact. I don't know which one of you wants to start off with that.
I'll have a go with that.
Brilliant, thanks, Katie.
I think what's great is there is an increasing body of research that's qualitative, ethnographic, that is having an impact on policy. People are taking note. I think there's something about the thick description that people can really connect with. When I first started doing the ethnographic work, the first report, I thought, absolutely, no one will read this, no one will get it. But actually, I had the most incredible response in that when people read that, and it's, it's a big, 50,000 word NIHR report that they got, not just a journal article, people really, were calling me and going, Katie, we get it. That was the BBC, that was the Guardian, which ended up as a front page headline, which was crazy. But it really connected with people on a deep level. And I think particularly with dementia, is it experience so many people have in their families. People connect, whether they're policy, whether they're in the media, it resonates, the stories, they've been there. So I think if you can show that thick description of people's experiences, it can take that work further. And I think the thing that I found most interesting was that happened, I did want that to happen, but I didn't expect it. But the interesting thing for me was that once I had that exposure, the gravity shifted. So my research went from being a small piece of work to actually policymakers seeking me out. So that change of gravity became a really, really important thing. So sometimes I think we think that those big media things don't matter too much, but actually they do matter. So that gravity changed. So yeah, I have a lot of policymakers who I now collaborate with who really have a lot of influence on directly, on how care is delivered. Using my work and we're talking about it and we're collaborating, that wouldn't have happened without that. So I think there is an increasing body of evidence that you can draw on to say the use of our approaches do make a difference and can make a difference.
Can I just reflect back on what you just said, Katie, because something just strikes me, and I think absolutely what you said is just amazing, but it's when you're talking about thick description, and it's only really when I talk to other people who are sociologists or that know a lot about qualitative research that talk about thick description. And it just struck me as you spoke that maybe that's part of the issue, that in departments when you end up as a kind of jobbing qualitative researcher, and what you're able to produce from that is often not that thick description. It's often, well, you don't have the time, even if you collect it, you don't have the time to analyze it in that way. And I think that's such an important point. I've spoken a lot about not having that opportunity to really understand what you've got and, collecting the data. And it feels to me like you analyze one bit to answer what you're being asked to do and the other bit to try and find some time to do the rest of it.
Absolutely. That is always going to be the challenge, but I would absolutely say that in my funding applications, I make sure there is significant time for that process. Do not skimp on it. Do not skimp on sites. So, be bold about what it takes to produce high quality, detailed sociological or social science research that is really grounded in theory. Do not shy away from it. I'd say I shy away from some of the kind of my sociological interests. I probably shy away from that in applications, but I kind of hide it a little bit and then it comes out in the publications and then funders love it. So it's that process, but I think it's making sure that you're using the methods and you be truthful to the rigor of it. I'm quite, I feel very strongly about that. And I think using methods in a light way, doing a tiny bit of observation in a mixed method study when actually the PI doesn't know what they're doing. I'm really, I feel very strongly that that's not the right approach. It needs to be, you need to have team members who have that rigor and experience of the methods to really ground it in the theory, the methodology. And if you do that, then it can have real power.
I couldn't agree more. I just think it's quite interesting to reflect back. I don't know Jemima's situation necessarily, but actually, what you've said is the kind of thing that I've said, but coming from a different perspective, as in how do you manage being an early career in that place. But I think it's really important. That's a really important thing to capture. Kate or Alison, did you want to say anything on that? Or yeah, please, Alison.
Yeah, so I agree with everything that Katie has said. I think she's given really good advice. I guess ultimately what funding bodies want to know is that their money is going to be well spent. And so, and so that's the anxiety with what will be the deliverables at the end of a project. I think impact on policy is really hard in the timescale of most funding schemes that are specifically designed for ECRs, because I think policy impact takes longer than that. I think practice impact is easier in a shorter term. even if that's only local practice impact. You know, and I don't think local practice impact should be underestimated, because, you know, I mean, one of the things that I'm really interested in is, as I talked about in my presentation, it is about how local contexts influence things, and so you know, from my perspective, aiming to have an impact on practice locally in a particular context that you are able to know well through the course of your research is sufficient, and certainly any application that I was evaluating, that would be enough. I think national impact or policy impact is a much longer term thing that you have to be patient for. I mean, I guess, Casey, I think some of the impact that you're talking about now is from prior work, but that has been cumulative rather than necessarily being from your most important work. So yeah, I think that, and in terms of getting clinicians on board, in terms of wanting to collaborate with proposals in the first place, I think the fact that there is work out there now that you can point to that has had that effect is really important. That, you know, you can be clear that you're not trying to pioneer something that has no hope, but that you are drawing now on a tradition of work that has been able to have this demonstrable impact and situating your work within that tradition. But I mean, really, that's, you know, kind of just adding bits around the edges to what Katie said, I think.
Oh, that's great, thank you, Alice. It's another way to think about it, isn't it? About thinking about the different levels of impact. And as Katie just said, you know, she was quite surprised by the level of it. I mean, I think it's fantastic work, and you know, I think it should have that impact. But it's great to see that happening. Kate, did you want to add anything?
Yeah, just, I mean, I agree entirely. I think there's a growing recognition, actually, of the value of qualitative research. And I think we maybe think that people just want numbers, and actually people really respond to stories, you know, and that's what makes it real to people, doesn't it? And they make those connections with their own lives about why something is important. And just say, I was an early career researcher when I was doing the Life Stories project, and so I probably got lucky, but I also worked with a team, you know, of more senior researchers, and I think that is really important to be supported by a team in that way. And when we first put forward our proposal, actually the funders said, oh, we really like the qualitative bit, we're not so sure about the quant stuff. But you know, those focus groups of people with dementia, no one had ever asked people with dementia how they felt about life story work before. They just thought it was a good idea, so they were all doing it. But actually there hadn't been those conversations with people who'd done life story work about how they wanted it to be used and that sort of thing. So that was really, really valuable in and of itself, to talk to people and hearing their own words about things. So, and people funders did recognise that. So I think it's, don't give up.
I think there is a shift. I think you're right, Kate. Alison, you've got a question from Iris, who's asking whether there were any cases in which the patient or the healthcare professional returned to a repair after a conversation shift later in the conversation.
Okay. So do you mean they returned to the topic that was unclear?
I think that's what that means. Yeah. Return to.
Yeah. Yes. So certainly we do. Yeah. And you know, and depending on where that talk is happening, it might be more or less problematic to continue with it. So you know, certainly there are cases in our data set of people living with dementia who had particular topics that they like to talk about that they would repeatedly return to. And so a topic shift doesn't close something down forever, but it might close it down while you do the thing that is immediately necessary in order to be able to return to it later. So yeah, if I've given the impression that topic shifts are a way of shutting people up forever, I certainly didn't mean to do that. It's simply a means by which you can attend to something that is immediately at hand and then perhaps return to something else later.
Great, thanks, Alison. I've got a question for all of you again to say how you navigated, you might not want this, how you navigated the research ethics and governance systems, like everyone's laughing now, about your research studies, and whether about using emergent research designs with vulnerable groups, and did the HRA Rex or Uni Rex or whatever it is get it? I don't know who wants to start.
I think Alison's probably got a lot to say on this one, but I'm just going to say that absolutely, and it does fill everyone with horror. And I will also admit that after my first meeting with the NHS rec, I did actually cry.
Yes.
But clearly I've recovered and got through it. So, you know, absolutely, it was brutal. And I think the one thing I would say that my colleague Andy Northcott is amazing at rec applications and has supported a lot of people. So do get in touch with us if someone needs help desperately. We're here to help, because I think we all need to support each other with that process. But I would also say that yes, I think they do take quite a paternalistic tone, particularly in terms of protecting people with dementia. I've had lots of discussions with our rec committees around, actually it's important that people with dementia are involved, their voices are heard, and that needs to be at all stages of living with dementia. So we have discussed that. I think there's a really interesting notion as well that I've had from a lot of committees around carers should not be approached after their person living with dementia has died. And actually we've made it really clear to our committee that that is when people need to talk. There is a lot of trauma that actually, rather than silencing, we need to actually give people the opportunities to talk and to share. So yeah, we've had lots of experiences and lots of challenges along the way that have been tricky, but I think as a community we have to support each other with, there are ways to do this, and I'm sure Alison's got a lot of tips about actually how to use film you know, in hospital wards. So I think together we can actually use more innovative methods and kind of move the committees to a place where actually we can do the research we want to do and not shy away from it.
Yeah. Alison, do you want to comment?
Yeah, I mean, I suppose my general comment is that I've been working with video data in healthcare settings that were sensitive for all kinds of different reasons for over 20 years, probably, or maybe even a little bit more than that. And always at the outset of projects, people say to you, you'll never get permission to do that. but always you do. So I've never had to abandon a project because it wasn't possible to collect the data that I wanted to collect. So sometimes that's required a little bit of backwards and forwards, but you know, that's sometimes necessary to make sure that things are pinned down really clearly and that everybody's happy. So you know, my kind of biggest bit of advice is don't be put off, because it is perfectly possible to get these projects approved. In terms of this specific project, I can't take the credit for it, because I work with a fabulous team of people who are really experienced in conducting research with people living with dementia. So Rowan Harwood, Sarah Goldberg, Becca O'Brien, Rebecca Allwood, Suzanne Beek, and so you know, they had protocols and processes from previous research projects on which we were able to draw and adapt. The really important thing about video data, I guess, is permissions and what permission you have from people to share it in which kinds of particular contexts and specific contexts, because obviously you can't guarantee anybody anonymity if you're showing video clips, and so that's the bit that I think is particularly important in terms of research dissemination to pin down, in terms of, you know, making it clear that people know exactly what they're consenting to and for what purposes. Again, in terms of the ethics protocol we had for the voice study, I know that we've shared it with others, and you know, our approach generally is that this kind of information should be shared. So I'm sure that we're perfectly happy to share it more widely if other people are interested to see it.
Thank you, Alison. I'd just add actually to what both of you have just said, which is just to say that some of the examples I've seen is it can be just as damaging to not collect all the things that you need, to not be bold enough with ethics and find that you're not actually able to do what you need to do with your data, because that's not actually very ethical in itself. If you don't have the permissions, if you haven't videoed recorded something when you needed it video recorded, or you haven't recorded it when you needed it recorded, the kind of analysis you want to do can be just as damaging. So it's worth really pushing, you know, well, being honest about what you need and why you need it. And I think, as with anything, you need to only collect what you need, but you need to ask for everything you want. A bit like Katie and Alison have both said. Kate, have you got anything to add?
Yeah, just again, I think things are getting better. I would say that when we first started the Life Stories project, there was quite a lot of backwards and forwards about, we were saying, we weren't sure about written consent and could we get verbal consent, and they were like, no. And more recently in studies, people have said, yeah, because it's like, you know, signing things can be quite stressful for people. And so just a bit more kind of understanding that actually the ethics kind of goes both ways. It's not just about getting consent on paper, it's about not disturbing and upsetting people, and doing things kind of that follows how they would like to do them. We originally talked about process consent in our original application forms, and they were like, no, we just, you know, need to get it on paper at a certain time. And whereas I don't think that would happen now. I think there would be more of a kind of understanding that these things have been developed because they're good practice. It's not a way of getting out of ethics, it's actually a way of being ethical. So yeah, I feel positive actually, and we haven't, you know, like Alison said, I mean, we've never been turned down for the work we've done with people with dementia, and the consent stuff I was talking about was actually with the focus groups, because in the care homes most people didn't have capacity to consent, and we worked with consultees, and that process worked. I would say it worked fine in terms of the mechanisms. In terms of the actual care home setup, it's very complicated because you've got to get people to contact consultees for you because you haven't got their personal contact details and everything. So it's still complicated, and it probably could be easier, but don't give up. It's definitely worth doing. And I don't think ethics is a reason, you know, as in getting ethical approval is a reason not to do something. It's just about finding the best way to do it.
Yeah, great, thank you. So Janina said all the presentations are excellent. I feel there's a juxtaposition between the life story work and the work around conversation responses. The more we understand about people as individuals, the better we can engage with those conversations that at first hearing don't appear to give a response that fits the question. Thanks all for a really interesting afternoon. I don't know whether anyone wants to respond to that, and just, yeah, something about the life story work and around the conversation that produces some kind of juxtaposition. I don't know if anyone wants to comment on that.
Well, we were doing very different research on different things, Alison. So
yeah, absolutely.
Yeah, I don't know, Alison, do you see any relationships between those?
I mean, I think that certainly the more, you know, it's back to context again, I suppose, and that, you know, the more context you have about somebody, the greater the resources you have to try and understand something that's difficult to understand. I mean, for me, I guess that takes me back to what I said at the outset of my presentation, that we weren't categorising these things as errors. We were just categorising them as things that in that moment were difficult for somebody to understand, and in that moment you need to find a way to work around them. And I guess however much you might know about somebody, there are always going to be moments where in that particular conversational exchange you can't quite make sense of what's been said. I think it's never going to be possible to reach a point in any context where you avoid the need for repair at all. I think that's just not how interaction works. But I completely agree that, you know, that importance of context is central to both sets of work, I guess.
I would say that there were instances where, you know, life story work was used, or life story information that staff knew because they had been involved in life story work, was used sometimes when people were distressed or they were in crisis. So anchoring people, bringing them back to something. So it's a bit like that kind of topic change. If someone's really kind of going round and round about something stressful, to be able to have that kind of bank of knowledge about what does that person find calming? What is it in their life that they kind of go to as an anchor, and something that that's reassuring for them? And we know that because we've done life story work with them. Well, maybe we can bring the life story book over and go, you know, show them things or talk about the things that we know are meaningful to those people. So it was used in that way. So I see in that sense it could be complementary.
And I think that's,
yeah, go on, sorry, carry on, Alison.
I was just going to say, I think that's really interesting because it also comes back to the point that you might on paper look at topic shifting and think it's not a very patient-centred or person-centred thing to do. But actually, as Kate's just said, if somebody's exhibiting distress and you can find a way to relieve that distress by talking about something else that you know is important to them or for them, then actually perhaps topic shifting is the person-centred thing to do in that context.
Yeah, you know,
yeah, go on. Sorry, Kate, go on.
I was just agreeing.
Yeah. Oh, okay. No, I just thought, I mean, the one thing that I saw as not a juxtaposition, but really interesting in how they all work together, is that Katie tells us a lot about, you know, these routines, you know, and the work that has to be done, the timetable care, which I have to say, I think reflects kind of hospital. I have a bit of a thing about this, about how hospitals operate really for the hospital organisation, not for anybody else. And therefore with people with dementia, it becomes even more difficult because it's even harder for them to work out, you know, how things work and all the rest of it. But I thought it was really interesting that what you reflected on is that there isn't really that time within, you know, staff that's not recognised to be able to spend that time. And then Alison and Kate even talk about, you know, what you need to be able to do to spend that time. So even in that time that people can get to manage that care, even that becomes even more difficult. So it kind of, I felt they all really kind of built on each other to say what a difficult area this is, because, you know, Katie's told us how the care is being delivered in, you know, in terms of that context, but even when you're able to drill down as Alison has done, and, you know, and as Kate's suggesting, you know, these ways of understanding, being able to work with people, actually, you know, the whole altogether, it just makes it really difficult to be able to do any of these things, not to be really negative about it, but just to really understand what these issues really are.
Yeah, I thought one of the unifying things that I spotted was permissions.
Yes.
And I thought it was really interesting just in terms of the looking at the ways people talk, the kind of permissions and the lack of permissions for people to talk or moving on. But in Kate's work as well, the staff who actually, you know, it sounded like they didn't do a lot of the work because in terms of the story work, because they didn't feel they had permission. There's something kind of deep seated in those organizational cultures about permission. And if you're seen as not doing the work that's, you know, that's permitted in an organization, you feel it very deeply. I think in healthcare organizations, it's powerfully felt. It's almost an anxiety there, which is, you know, again, goes back to the very old organizational nature of these settings.
I would agree entirely. And I think that there was very much kind of like, in theory, they've been told in a training session that they had permission, but in practice, there was no allowance made for that. So it was like, well, I've got beds to change. And it was like, and people were saying, oh yes, but build it in. So when you're bathing someone, talk about their lives. And it's like, well, yeah, maybe I do that. But when am I going to make it into this fancy product that we're going to do? And people were keeping little slips of paper, but it's all kind of additional work. Yeah, and the permission, I remember even for filling in the questionnaires, people were saying, I'll take it home with me. I'll do it in my own time. Even though they've been, you know, ostensibly kind of told that it was something that was part of work. It wasn't part of that kind of idea of what I do in my job. And there was a feeling, there was really quite strong hierarchies in some of those settings where it was like, well, I'm going to get told off. If I don't clear this mess up, or, you know, sort out lunch or whatever, I sit here and fill in a questionnaire, I'm going to get told off. So I'm not going to do it, understandably.
Yeah, exactly. And they're the social processes we really need to understand and unpick if we're to make those changes and interventions that are going to have any impact on, you know, supporting the person with dementia, but also the staff. They go hand in hand. We have to improve circumstances for both at the same time.
Very much so.
Yeah, absolutely. I just want to thank you all. I'm going to just draw this to a close now. It's been, I really enjoyed it. I think it's been a really, really interesting afternoon. So the idea came from trying to try and champion the kind of really great qualitative work that's going on to try and understand ideas around innovation, implementation science, but also policy, to try and take it all the way through. And I knew of, I knew some of the work that was going on with you all, and I thought this would be a really good opportunity to get everybody together. So, sorry, it's all a bit hot, isn't it? So I've really enjoyed it. I hope everybody else has. You've had some fantastic comments going through the chat. For people who've taken part, there is a questionnaire which Charles put in the chat, or just a brief survey, if you could just fill that in just for our metrics. We will also put the recording up on the website once it's all been sorted, and Charles is sorting out access to slides as well. But it just really remains for me to thank all of you, and Jill, who's obviously gone, but to thank the three of you. It's been great, and I've really enjoyed the discussion as well. And I think it's been really nice to reflect on the place of qualitative research in all these different areas, and also I really like the idea of trying to get people together to understand qualitative research isn't just doing an interview with someone who's part of a trial, or just going asking somebody, because we just need to know that first bit to do the proper real study later on. And for people to realise, you know, it is more than, but Jill put that up, it is more than an interview. You know, it's important to interview people, but actually, you know, this isn't about interviews, this is about doing a different way of trying to understand what's going on. So so thank you all very much, and I hope to see you all.
Thanks for inviting me, much appreciated.
It was great, thank you. Brilliant. Thanks very much. Thank you, and enjoy the rest of your holiday, Alison.
Thank you.
Great, thanks.